Awesome. Again, good afternoon. Thank you for joining us today. My name is Marjan, and I am the Education and Learning Lead at FCBC. I'm here with my colleague Stacey Dawes, who is our Health and Community Engagement Lead, as well as our guest speaker, Dr. Adam Hoverman, who is a family medicine physician with the Wellington Medicine Clinic and co-lead for social prescribing at the Nanaimo Division of Family Practice. He's here today to talk about caregiver integration in primary care through social prescribing and how to implement FDBC's Caregiver RX referral pathway. Just before we get started, oh, all right. Sorry, before we get started, I'm just going to do a quick acknowledgement of the Lekwungen peoples on whose unceded territory the FTBC office is located, as well as the Songhees, Esquimalt, and Wasanic peoples whose longstanding relationship with this land continues to this day. I'm currently joining in from home, which is on the unceded lands of the Coquitlam First Nations, and I welcome you all to introduce yourselves in the chat and let us know where you're joining in from today as well. So without further ado, I will pass it on to Dr. Hoverman to get us started.
You're muted. I know that you're saying very important things.
Thanks, Tim. That's right.
Thank you.
So now let's begin. It's really good to be with you all here today. And thanks, Marshawn, for the gracious invitation and introduction. It's been a journey of several years getting to this point, building a set of really fantastic partner collaborations in looking at how to integrate caregiving here in my practice, both as a family physician, but also as a preventive medicine public health physician and co-lead for social prescribing within an Nanaimo Division of Family Practice, really thinking about this question of how do we improve social well-being. So that's the aim for today in our brief time together this afternoon, talk about how caregiving is a manner of health and social care and the role of co-production for partnering with caregivers in that regard. And that social prescribing, and particularly the FCBC's Caregiver RX is a model social prescribing program. Talk about how the existing and available caregiving support networks are functioning across the province, and see how we might further learn from other countries for appreciating the vital role of culture in this process for improving health and social care. It took many years through medical education to come into contact with this definition of health, which I did not know at the outset of my medical education. But to learn that in 1948, the World Health Organization inscribed a definition of health that is complete physical, mental, and social well-being, not merely the absence of disease or infirmity, really raised for me the concern as I began to see the gaps early on in practice. Social well-being being left out of the daily attention that we give for caregiving in practice. Another way of saying that is that caregiving is another form of bringing co-production, that is to say, the skills that everyone has in wanting to improve health and healthcare into discussion, saying everyone who relies upon a system has a voice and a manner of contributing, however that set of skills might exist, for these outer rim of the habits of daily improvement that Bill Lucas and colleagues have framed for us, for how we might then improve our communication, collaborations, and quilting the system together to further co-produce in health and social care. Family Caregivers has done this for decades here in BC. First as a community-based organization in Greater Victoria in the late 80s, but then growing across the province, and now the home of Caregiver RX, with the three pillars of caregiver support, education, engagement, and collaboration. And really bringing to light the value of elevating the role of caregivers and the need that they have to feel and be supported meaningfully in improving the quality of the care to their recipients, as well as their intersections with the healthcare system. That foundation of identification, referring, and support, say, is threaded throughout all Caregiver RX programs and Family Caregiver BC interactions that I've had. But how to improve on this is really why we're here today, talking about the intersection with social prescribing. There is a theory of change that really has been developing in the last 10 plus years for getting the public aware of Family Caregiver BC's role, to refine its integration and embedding opportunities into primary healthcare settings, but ultimately to tell the story. And I think that's why you're all here today, to hear what's happening across the province and hopefully scale that in a more tightly connected network here together with the 23 some on the call at the moment and those that you work with daily. Further, it's a way of applying the model for improvement from Institute for Healthcare Improvement and colleagues such as Health Quality BC's efforts. Really applying the Plan, Do, Study, Act is such a vital piece of this. So how do we take the question of what are we doing and how can we do it better? But more importantly, to take the time to reflect, where are those barriers? Where are those balancing measures that we should pause and think further about tests of change that could even be tried as early as next Tuesday? So this is one call to action I have for y'all today. Think what you might start by doing next Tuesday in this regard, as it applies specifically to the embedded order sets that have been applied or been made available through pathways in several clinical settings here in Vancouver Island, in Sandwich Peninsula Hospital and Royal Jubilee, through clinical order sets, referral forms that we now have here at Wellington. That is part of the reason why I was invited to share this talk with you all today, which is a PDF form that we've integrated into our electronic health record that can be completed at a visit with the consent of the caregiver and then faxed to Family Caregivers of BC, which I'd say is a little more of a robust and response rate to how I would on many occasions in this very room pull out the prescription pad, write, please call on there and hand it. And really the dozens, if not hundreds of those that I've given that have been shared with me in response by caregivers who said, I just left that on my kitchen counter and never got around to calling. It was just another item on the to-do list. So I'd say for efficiency in the primary healthcare setting, these embedded referral forms have been the greatest through line for connecting caregivers, connecting caregivers from this clinic room to Family Caregivers of BC supports. And you can see here from looking across the province that those consent referral forms in both embedded and non-embedded sites have had a greater turnaround for compared to repeat referrals. Looking across the province, over 60 communities have been engaged for Caregiver RX programs, with 240 annual caregiver referrals overall from the program to connecting caregivers further into community programs, as well as 1,300 touch points for those such as me and related healthcare providers working day to day. And so we've seen a great increase in this over the implementation of such programs of embedded referrals. Now, why is this meaningful to me, you might ask? As one who early in my practice, in the 2008-2009 era, learned about the World Health Organization's Commission on Social Determinants of Health, I heard about studies that looked at communities such as Roseto, Pennsylvania, which is where this photo is from, that found that in the comparison to surrounding communities, those that were multi-generational, that had a great deal of social solidarity and community-based supports, that had a lesser ostentatiousness, even for those who were wealthy in the community, but particularly as germane to our topic here today, those that had the intergenerational supports in the homes and in their neighborhoods were significantly increased life expectancy vis-a-vis a decreased mortality rate from mortality attributed to myocardial infarction. And that made me quite interested when I first learned about this 20 some years ago, and thinking, how does one improve life expectancy when our tools in health care can sometimes be limited and still improving, as they say, medicine being the youngest science? Applied to our local region, this map really dramatically affected my practice in this regard. And you can see at the 49th parallel, longer life expectancy in regions scattered throughout the province, particularly in rural and remote areas, with the darker areas being greater than 80 life years estimated life expectancy at birth, that is, from 2012 StatsCan estimates compared to the CDC Wonder estimates of the border. And we might say, what is it that beyond just access to care in municipal areas helps improve that life expectancy? And I believe caregiving is greatly a part of that benefit. Further, when we look at life expectancy compared across countries, the work of Stephen Bezrushka from the work of the Health Olympics, that is a coined phrase of if health is an Olympic sport, with life expectancy being a gold medal or medals being given to those with longest life expectancy, Japan would consistently win the gold medal over several decades now. Whereas here we sit in Canada, once being in the top 10, now at 16 from the most recent UN Development Report estimates. And what might we learn in this regard from those 15 countries that have longer life expectancy? I think it's comparable to the Rosetta effect and worth our consideration for not only the approaches to improving access to care in those countries, but also how caregiving is a byproduct of the culture and simply the way of being human and alive in those settings that we could learn from. And thus, this is where social prescribing comes in, and how the National Academy of Social Prescribing has brought together a community of practice that includes now the Canadian Institute for Social Prescribing, with supports from the Canadian Red Cross, United Way, and other supports, really recognizing that we have, as humans, a universal need to connect, and now the science to demonstrate the value and the benefit that comes from both healthy and long lives in this regard, with the World Health Organization's Commission on Social Connection released this summer, and the U.S. Surgeon General's report on the same topic in 2023. We have the science and the evidence to show that these are important concepts to put into practice. Case studies that have been gathered by the National Academy of Social Prescribing have been published in this way and can be reviewed. I highly encourage seeing how it is unique to each given setting, and also how the World Health Organization provides a toolkit for implementing social prescribing that we've used here in Nanaimo with support from Shared Care, and a partnership that was developed through that support over the last 2 years with Vancouver Island University, Department of Recreation and Tourism, and the School of Nursing, Island Health's Community Health Services, the City of Nanaimo, Parks, Recreation and Culture, and the Division of Family Practice, seeing how best we could implement this link worker idealized role so that bringing a link worker as close as possible into the primary care setting would allow the identification of loneliness and disconnection to then have a link worker ask the question, importantly, what matters to you? And then go with them to the organizations in the community where that can be responded to in a meaningful way. And ideally also applying that PDSA, Model for Improvement, Plan, Do, Study, Act, to improve with each iteration of that link worker prescription. In a way, the Caregiver RX program is just that. If we extend further to think about link workers being anyone who plays a caregiving role. So not just a job description as a link worker, but in this regard, any and every caregiver in the province getting to play that distributed role as link worker. And here we can see that Saanich Peninsula and Royal Jubilee and here at Wellington Medical Clinic embedded processes for connecting those caregivers with the Caregiver RX program to then connect with the community-based programs has been quite successful in the last several years and growing annually. So truly, compared to those sites that are embedded, we have a fourfold increase on average of connections with caregivers to community programs through embedded sites, worth building upon and improving as we go. Here's a map across the province of those referral sites, and you can see the Lower Mainland, Nanaimo, and Victoria, where the demand has been the strongest for the hearth healthcare partner network for both embedded and non-embedded sites, and the support engagement spreading further, but still strongest and most robust in the Lower Mainland and Victoria, which helps shift resources in those directions. But my hunch is, and I would be keen to hear from those outside of the hotspots on this map, perhaps in rural and remote locations of the province, who might know where there is a caregiver need as well that we could extend further through the networks that we're building here today. And furthermore, to then help nudge and encourage those community referral sites, the caregiving programs, where that caregiver RX connection can then get the caregiver connected to the community, which I think is really where the meat of the matter begins, which is to know that there are neighbors and supports directly, vividly, in person accessible in one's own locale that provides that support and encouragement, nurturing, and a sense of well-being that comes by feeling you're not alone. You can see most pronounced here, again, the Lower Mainland and across the island. But where might we envision these caregiver programs to develop further is one of the aims and calls to action here today as well. In Nanaimo, we began this conversation past the development of the Link Worker program and Link Worker referral through Community Health Services and Island Health by hosting Julia Hotz for a community-wide conversation back in March in conjunction with International Social Prescribing Day. And if you haven't seen the book yet, I highly recommend it. It's essentially a condensed reprise of the several decades of social prescribing experience around the globe. And with a book talk and many community leaders and community members interested in this topic, we began looking at how better to partner with community organizations to shift the question of what's the matter to you to what matters to you in meaningful, measurable ways. Recently, as a bit of another case study, and in particular as a personal connection that has been made through the National Academy of Social Prescribing, I've been able to see what this looks like in practice in Turin, a recent trip in October to Turin, Italy, to see how in the southeast quadrant of the city, with a population of about 220,000 individuals, a former hospital that you can see here, psychotherapy hospital from about the past 100 years, sitting abandoned for the last 10 to 20 years, was donated from the city to a social prescribing program that brought together a clinic embedded in a library that then had adjacent programs on a daily basis with a social bistro run by users of the clinic, all within the same location. They too were implementing the World Health Organization's toolkit on how to implement social prescribing with the link worker model, with link workers that were not only from connections with the local university, but also those who were coming through the program and raising up their skills through the wide array of supports they had embedded in that setting, as described here. And so coming back, though they were delighted to hear where we were at in our iterative learning with bringing and implementing social prescribing in Nanaimo, I'd say there's still much to learn from those case studies of where social prescribing is happening vividly and in practice, not only to improve the need for caregiving and setting a care agenda in all practice of health and healthcare, but particularly how social prescribing can get us there. And with that, I'll pass the microphone back to Marjan and Stacy for other ideas and thoughts. I look forward to your questions that you might raise here today for our discussion in the final 10 minutes or so of our time together, and look forward to staying in touch. Please feel free to send an email and reach out. Over to
Thank you
Marjan.
so much, Adam. You jam-packed a lot into those 20 minutes. Now we're gonna put it off to all of you. We turn this into a meeting because we want this to be interactive. So if you want to ask any sort of questions, you can either put them in the chat or you can just put your hand up and take your mic off mute. And yeah, let's chat about social prescribing. Any questions?
Not really a question, but more just of a comment when you show the map of British Columbia and really just highlighting the needs being different in different areas and really the needs very different it, excuse me, in an urban setting versus in the rural setting. And that was really picked up on in our meeting that we had yesterday with Stacy and the community of practice, where we did have different representation from different parts of the province and just even the challenges of getting people out to support groups, caregiver support groups and that kind of thing. So I think in all types of programming, we have to be so mindful of the differences that location makes, and in terms of the resources that are available to people, but also in terms of what needs they may have, those two different things. So it's not really a comment, but just more of or it's not a question, it's more of a comment.
Well, thanks, Elaine. I absolutely resonate with that. I have sat with the frustration that many of those caregivers that are in my practice that sit in this room and tell me they have enough on their to-do list already with their work of caregiving, that all those barriers of transportation, of not having familiarity with that further group, or let alone this organization, I think really requires many more warm handoffs, but also hopefully this sense that we are all link workers in the end, even those who wear this jewelry, for helping build that bridge of friendship and trust.
We have a question in the chat box here. Just curious if there's new learnings around seniors who might mistakenly get placed in social prescribing programs or confusion when joining program, not sure how to stay engaged, follow up, etc. Thanks, Devin.
Well, I think what you're calling out is the need for further applying that model for improvement here. I can say for certain, in Nanaimo, we're at the earliest iteration of putting this into practice and have yet to do full-scale focus groups and or seeing the long-term outcomes of those referrals, let alone, I think to your point, around if they hear from a health authority contact that this is a program that they have not yet heard about, how to better build the familiarity with social prescribing. So if that your question is about the confusion of what is social prescribing to begin with, that's the bigger work I feel we have together here to say that this is how do we bring social well-being back into the practice of healthcare and reduce that confusion so it's seen as part and parcel of what we do.
Do we have any other questions?
And in a perfect world, it's about back to that slide where you talk about what matters. And then there were a couple of points underneath that, right? And then the last one, I think, was do what matters. And I think, again, for those of us who are working on the front line, so to speak, it's they can identify what matters. It's then the doing what matters that we just have such a difficult time executing because of the limited resources.
Well, Elaine, if I may, if anyone doesn't have a burning question, I think this is where I'd like to take the analogy. If we're going to be giving social prescriptions, then perhaps we should be looking at how we develop social pharmacies as well. And not just social pharmacies, but social pharmacists. And if I can share this for you here, there is a connection with the pharmacists in Australia. They have a program that's been called Pharmacists Addressing Loneliness and Social Isolation. And that has been in a part of building this bridge. How do we try to open the slides here? How do we learn from where they have pharmacies also a part of the conversation for the doing, right? For the dispensing of this, which I think is a hard way to get our brain around. If we go from what it took for Alexander Fleming to recognize that mold on the bread killed the bacteria, it took still many, many, many years to be able to get penicillin able to be dispensed from many pharmacies as well as put into, injected into the body. And we're at that same stage. We're at that early red mold stage for social prescribing. We know that there's a benefit for this, but how do we then get it so that it's in the doing day to day, where it's seen as analogous to all of our work in healthcare, and how hopefully before long there will be a way by which to say the doing is not any different than asking what matters to you at every encounter of healthcare. So here in Nanaimo, I just want to share this one particular slide. There is a workbook that I would encourage everyone here to consider using, called the What Matters to Me workbook. And that was through the Physician Quality Improvement Program in Island Health this past year, used as a way to begin the conversation with 5 pharmacies here in Nanaimo. The workbook was developed out of the Being Mortal project of Tul Gawande and others at Brigham and Women's Hospital, and previously known as the Serious Illness Conversation Guide. Out of feedback, not only from the Nanaimo experience here, bringing the City of Nanaimo social planning team and United Way's healthy aging team into this conversation, they now call it a workbook for better healthcare. And I think just like the CARE, caregiver tool that's used in the conversations, I think the What Matters to Me workbook offers us a great deal of how do we shift that conversation towards what matters to you. And distributing this workbook is just one way of many, I believe, that will get us towards the doing that you're talking about, Elaine, quicker when we know what matters and then can see that there's a wide array of abundance resources, oftentimes just outside the door, to answer that question and reply. I'll put the link here in the chart. Oh, thank you, Barb.
I think Barb has already beaten you to it. Thank you, Barb.
Thank you, Barb.
I'm just looking at time here. We have a couple more minutes. I just wanted to ask if there's one thing that you wanted for people to take away today. If they were to start social prescribing tomorrow, what is the one thing that they can do in their practice? Tough one.
I guess for everyone here, from what I understand at the top of the call, that many are caregiver are working in primary care settings, are maybe in urgent care or in community programs. I think recognizing that the question, what matters to you, to each of you, is a vital piece of this, right? So to remember that you're here because of what draws you to this work, and to know that at some point we all will both be caregivers as well as recipients of care. And I think that is where much of what generates the passion for social prescribing for me begins. You know that this is, as has been said, about a manner of Ubuntu, that a person is a person through other persons. And that way, I think, is where you can even try by next Tuesday, recognizing that a colleague, a friend, family member that you get to express care for now will someday reciprocate for you. And that's where social prescribing really at its basis can begin. Now bringing that to practices in primary care settings and recognizing that we have a long way to go to build the familiarity, as Stefan's question brought up earlier, is the work ahead. And I look forward to continuing the conversation as the months and years go by with you all. So thanks for your attention here today.
Thank you. And thank you for your leadership and for showing what's really possible when caregiver support is built right into everyday practice, and having those conversations with patients and caregivers. We're obviously very, very grateful for your partnership, and really, truly appreciate the commitment that you've put into this work. That is all for today, folks. We thank you all for attending, and for the rich questions and conversation. And this is recorded, so we'll be following up with some additional resources as well as a webinar if you would like to share with others. Enjoy the rest of your day, everyone.
Take care.
Thank you, everyone. Have a great day.